All right, hello everybody. This is Claire Trencaise with the Oregon Primary Care Association. I hope that you are all logged in successfully to our platform. Please send a chat through the chat box if you are experiencing any technical difficulties. We can try to troubleshoot that for you. So, thank you again for coming and joining us today on this webinar. This is our second Special and Vulnerable Populations webinar of our series. Our first one was on language access plans, and then we do have a next one lined up for June, and that will be about LGBT health. But today we are excited to share a lot about HIV care in Oregon. We have some great experts here who are going to tell lots of great information to you because we here at OPCA only really know about a very small bit of this information and UDS, Uniform Data System information. So just to let you know, we are going to be recording this webinar so that we can share it with folks afterwards. And please do send us questions through the chat box throughout. We will monitor that, and we may even take some pauses to see if there's questions. But we do have a lot of content we're going to try to get through today. Yeah, so, one thing I've realized is I have learned a whole lot about HIV care here in Oregon as we have embarked on putting together this webinar. In particular, I had the pleasure of visiting the Multnomah County HIV clinic, and they really provide a lot of the care in our state. So it was really great to get over there and see them. They're only about a block and a half away from our office, and it seems silly not to go visit. They have a fabulous medical home model that they are using for care there. And so, your patients are in good hands if you refer them over to that clinic. So today, just to review our agenda briefly, we are going to take a few moments to just talk a little bit about the new 2014 UDS measure on first-time HIV diagnoses and referrals to care. And Max and Krista here from OPCA are going to share that information with you. Then next we're going to talk a little bit about routine HIV screening and linkages to care, and we have Dr. Melissa Murphy here and Dana Morrison from the AIDS Training and Education Center, housed up at the VA. And then finally, we will have a little bit more information about resources and referrals statewide from Margie Robinson from Multnomah County and from Anik Benson from the state. So that is what the agenda is going to look like. And looks like things are moving along well, so I'm going to go ahead and hand this over to Max to share a little bit of information about our clinic.
Okay, the first couple of, this set of slides about the UDS, don't try and copy the numbers down, don't try and memorize them. There's probably only one person out there that cares about this stuff other than me. And two, we're going to be sending you out a hard copy of it for your records if you're interested in it. Anyway, just to tell you about it, basically, according to the UDS report for 2014, which is the most recent data, there were 1,623 HIV patients treated at the FQHCs in Oregon, of which 1,383 were treated actually at Multnomah County FQHC. So it's very clear that in Oregon, the FQHC volume is all at one organization. There were 14,876 visits to FQHCs by these HIV patients, and of which 14,200 were, again, at Multnomah County Federally Qualified Health Center. So that's the historic trends, and we've got some graphs in the next slide. Not yet. The new measure is it's a measure of the newly diagnosed HIV patients. So these are patients that come to you, and for whatever reason, you do an HIV test on them, and the first time they are diagnosed as having HIV occurs at your organization. This is a brand new measure effective in 2014. This is a relatively uncommon occurrence. In fact, there were only 148 patients diagnosed for the first time having HIV at an FQHC in 2014, in Oregon that is, again, of which 101 of these were at Multnomah County. They are the 800-pound gorilla for HIV care. The point is that these patients that you diagnose at your organization for the first time, you have to start keeping track of them because there is a new measure that the Bureau is using for us. It's a quality measure. They are trying to see, are we really performing like a medical care home? Are these patients being treated like a patient, or are these patients being treated like, okay, this is something we need to get to somebody else? And the way they're measuring that is, your quality measure is, if you diagnose them for the first time as an HIV patient in your organization, best practice is you will see those patients within 90 days. Real best practice is you will see those patients within 30 days. But the rules they're playing by, they're going to give you 90 days because if you're in Timbuktu and they're in West Timbuktu, it may take them a while to get back to you, even if you are really trying to get them back in. So this is a measure of how good a job are you doing of acting like a primary care home. You may later transfer their care for AIDS to another clinic, one that has more AIDS patients, has more expertise in this area. But the real question is how did you treat them on the front end? That's what they're measuring. This is going to become a really important measure down the road as to, are we doing what we say? So that's why we're wasting time at the start of this meeting, which is about patient care, talking about UDS stuff. The rest of the graphs show a very interesting, some very interesting numbers. This is the graphic representation of the number of HIV patients over the past years and where those patients are. And again, you can see clearly on this one, the HIV patients are in what we say is Multnomah, which is really the Portland metro area, if you're really talking about a geographic location kind of system. The interesting thing is there is a trend here. The trend on the prior sheet was a slight increase every year in the number of HIV patients. The trend on the second thing is every year a slight decrease in the number of visits. Now, this could be because we're rationing care. That's not true. What it is we're figuring out how to treat these patients better and more efficiently and not doing come back in 2 weeks regardless of what's happening. It's come back in if you need care, if we can do something for you, or if other problems develop. It's actually a sign that we're growing in our ability to provide the proper care to these patients, which is good. That's always nice when we're going in the right direction. And that's basically the graphs and the numbers we have. Included in the verbiage is the actual directions out of the UDS 2014 manual that just says this is what you're measuring. And that's the numerator is the number of patients that are diagnosed with HIV for the first time at a visit at your clinic. And the denominator is the number of patients. Well, anyway, the numerator is those that received care. The denominator is those that were diagnosed. I was saying it backwards. I apologize. Here is a wonderful thing that you can't read because it's very small. And again, look at the hard copy. That is readable. It shows where each of the HIV patients are. There is one notation that whoever does the UDS report in your organization needs to be reminded of. And that's HIV is measured in 2 spots on the UDS report. It's on table 6A, and it's also on table 7C. Table 7C is the quality measure, which takes your number of newly diagnosed HIV patients and divides that number into the number of your newly diagnosed HIV patients who got care within 90 days. That's your quality measure. The measure on table 6A is your number of HIV patients and the total number of treatments that had that diagnosis attached to it. So that's your existing population, your total population, and another measure on it is your number of newly diagnosed patients. The numbers on at least 2 occasions this last round, the number on table 6A that said this is our number of newly diagnosed HIV patients, and the number on 7C, which the denominator is supposed to be the number off of 6A, they did not match, which tells me that probably 2 different people were doing the measuring, and they didn't talk to each other. The Bureau didn't squawk about that at this point. At some point in the future, they're going to say, clearly, you're making up numbers and give everybody a hard time. So just tell whoever's doing this, check to make sure everything crossfits. If you say you have a newly diagnosed patient on table 6B, make sure you have the same number of newly diagnosed patients on table 7C. That's just, a hint to the guys like me that fill out the UDS report. And again, we have nothing to do with treating patients, and so that's not anywhere near as important as everything else you're going to talk about today.
Thank you, Max.
Thank you.
All right, thank you, Max. So you guys just heard a nice summary of some changes to the 2014 UDS report. So my name's Krista, and I'm the Performance Improvement Manager here at OPCA. So what that really means is that I spend 90% of my time just understanding clinical workflows and how that all unfolds in terms of data and quality improvement. So the next, how many minutes? About 5 minutes or so, since we have a lot of you on the phone, and Max just gave a really great overview of the new data that your centers collect, I thought it would be helpful to touch on really 4 points and see what kind of discussion arises. So this is interactive, and I hope that all of you feel willing to share. So the first question to the audience is, how does your organization currently screen and document for HIV?
I don't know what that means. Yeah, it's the same request. It'll build, like, if I... Oh.
You.
So, DJ Edwards, you're currently muted. Let us know if you have anything to say. But does anyone have anything to share about how you currently have this workflow? How do you currently screen and document for HIV in your centers? And then if you have anything to say, please feel free to add it in the chat box as well. Okay. Anyone to share? Okay. So moving on to the next question. So workflows for tracking. So Max brought up an interesting point. So tracking the number of newly diagnosed patients is a new thing. The way EMRs work, it would have to be a little cumbersome and difficult to go through and find out, was a patient newly diagnosed at your center? In fact, in a lot of cases, it's not even possible unless you flag the patient. So I'm curious to hear anyone share. So what is your current workflow for tracking newly diagnosed patients, if you have one, just in general?
Must be why they're on the webinar. Yeah, I think the point that was made when we were talking about this earlier is that it really is going to be a manual process, because even if you have done the test, you have to know who was positive and if that was just in the past year, not in previous years, not that they just have the diagnosis, but that it happened for the first time this year, and that we don't necessarily have systems in place to track that systematically yet.
Yeah. And then a couple other questions. So, and this goes to anyone on the phone if they'd love to share. Do you have a practice that you currently refer to on a regular basis? Right? Oh. Okay. All right. So last question. So since we're getting some dead air, and just feel free to share. This is definitely your opportunity to connect with other clinics and share your experience, since you will have to be reporting this. How about closing the referral? What's your current process? All right. Doesn't sound like we have a lot to say. All right. Well, thank you.
Well, thank you for Krista. I mean, I think these are important questions, and probably the reason you guys are on this webinar is because you don't necessarily have these systems in place. So these are the things we would like you, these questions, keep these in your mind as we go through the rest of this webinar, because you're going to be getting some answers to some of the best ways to screen and to document and to make sure you're getting clients to care, and where you can refer them and make sure that those referral loops get closed. So thank you to Krista and Max for sharing some information on our UDS data. And next we're going to have Dr. Murphy share some of her slightly more clinical data around it. So let me get her going here. So I'm going to start with just an overview of why HIV screening is important, and then touch on what we use to do that. So at this point in time, there are over 1 million people in the United States who are living with HIV. And despite all our advances in antiretroviral therapy and the treatment of patients with HIV, we continue to have about 50,000 new HIV infections each year, roughly for the past decade. And this is mainly due to the fact that half of these are acquired from people who didn't know they were infected with HIV. And if they knew they were infected with HIV, certainly they could change their behavior in terms of getting on antiretroviral therapy and using condoms with sexual activity, which would significantly decrease the transmission. So the fact that half of these infections are acquired from people who didn't know they were infected suggests that we're diagnosing HIV a little bit too late. So we've already sort of heard about Oregon, so I'll just touch on a couple of points. There are, at this point, 4,685 Oregonians living with HIV as of October. And if you notice from this picture, the majority of these are along the I-5 corridor, with about 50% living in Multnomah County. There are, if you look at this, this is an updated slide, and you can see from the little yellow dots those that have viral loads greater than 10,000 copies, which means they're not currently in care or taking the treatment that they should. So we have a lot of work cut out for us still. So as it turns out, unfortunately, only 41% of Oregon adults have ever been tested for HIV. So we still have a lot of HIV screening to do. So during 2008 to 2012, 39% of Oregonians who were newly diagnosed with HIV had severe enough immune suppression to meet AIDS criteria within 12 months of diagnosis. And that essentially means that these individuals had likely been infected for greater than or equal to 7 years. And that data is based on the multi-AIDS cohort study. So this is a graph from that study. This study was done out of Johns Hopkins starting in the early 1980s, where they took tubes of blood and they acquired clinical data from patients as they were diagnosed. So this is how we understand the natural history of untreated HIV infection, because bear in mind that HIV was discovered in 1982, but we didn't have therapy that altered the life course of HIV until 1995. So the main reason that we're missing a lot of these patients, if you notice in the graph here, see if I can get the arrow, there is a prolonged period of clinical latency in the course of untreated HIV infection. And during this period of clinical latency, people are completely asymptomatic. They may not know that they have HIV and therefore can be transmitting HIV to other individuals. So HIV is frequently symptomatic in the very early part, which is primary infection. But interestingly, primary infection with HIV is really indistinguishable from many other viral infections, so frequently goes undiagnosed. So as I mentioned, it isn't until about 7 or 8 years into infection that people start to develop symptoms from HIV. So this prolonged period of clinical latency is why we're seeing so many cases of transmitted HIV infection from asymptomatic individuals. And unfortunately, by the time we're diagnosing people, it's a little bit late. So when you look at the last decade or two, the CD4 count at which we've wanted to begin therapy was 350 cells. And if you notice from this graph that the majority of patients were coming in with CD4 counts lower. So in other words, we're starting behind the 8 ball, so to speak, that the patient had already reached the CD4 count threshold at which we wanted to begin therapy before they even got in. So this is from the North American AIDS Cohort Coalition. There were 45,000, almost 45,000 patients in this study. So this has been a trend over the last 10 to 20 years that we really haven't done a great job of diagnosing people in a timely fashion. And part of the reason for this is that in the early days of HIV, we started with diagnostic testing. So that was performing an HIV test for persons with clinical signs or symptoms consistent with HIV infection. So that's essentially, as I said, 7, 8, 9, sometimes 10 years into infection. So all those people had a period of time where they were transmitting HIV and didn't know it. We subsequently, in the 90s, moved on to targeted testing, which is performing an HIV test for subpopulations of persons at higher risk, typically defined on the basis of behavior, clinical, or demographic characteristics. For example, men who have sex with men or IV drug users. But as you can see from the data that I've shown already, targeted testing really hasn't helped. And in fact, targeted testing has been somewhat difficult because people feel like they're being singled out in terms of testing. So the best and most effective means of doing HIV testing is screening, which is for all persons in a defined population. And it was in 2006 that the CDC finally changed the recommendations for HIV testing to go with screening and essentially made HIV screening part of primary care. So HIV screening is now recommended for all patients aged 13 to 64 years old in all healthcare settings, with the also addition that if a patient is at high risk for HIV infection, they should be screened for HIV at least annually. And as well, the U.S. Preventive Services Task Force has also updated their guidelines to suggest that everyone screen adolescents and adults, and their age guideline was 15 to 65 years, with, again, the caveat that if younger or older individuals have risks, they should also be screened. So the rationale for routine HIV screening, and the most important thing to remember is that the earlier the HIV diagnosis is made, the better the patient does because they can get into treatment at the appropriate time. We've also found out that routine HIV screening is cost-effective even in healthcare settings with low HIV prevalence. More patients accept HIV testing when it is offered routinely without a risk assessment. And my personal experience with this, when I would do I've been doing infectious diseases since 1999, and when I would see patients on the consult service at the university or the VA, and you would, for whatever reason they were in, maybe heart valve infection from using IV drugs, you would offer them an HIV test or suggest an HIV test, and a lot of patients would be taken aback and feel like they were being singled out, or you thought there was something wrong with them, or they were doing something bad, and that's why you wanted to do an HIV test. You know, we had initially, we were worried about testing when we started doing HIV screening at the VA, but what I found is that when a patient questions now, why are you doing HIV, why do you want to do an HIV test? And I say to them, oh, because we're now screening everybody. This is part of routine primary care. Patients actually are more than accepting of getting the HIV test because you're not singling them out to do it. It's something that everybody should have done. It's part of routine primary care. And then lastly, patients aware of their HIV infection substantially reduce behaviors that put them at risk of transmitting HIV. So I've been the director of the HIV clinic at the Portland VA since 2001, and I have to say my patients in general are very conscientious of trying to make sure that they don't transmit HIV to other individuals. They're more apt to use condoms. They want to get on antiretroviral therapy. And so if patients are aware of their diagnosis, they really do substantially reduce their risk behaviors. So talking a little bit about how patients do when they enter into care based on their CD4 count when they're first diagnosed. So when you look at this graph, you'll notice the correlation of the baseline CD4 count and their outcome. So if a patient, if you look at the far right, again, as I said, during most of this time frame, this is 12,574 patients. If patients come in with a CD4 count greater than or equal to 350, so that's when we want to begin therapy. So they're coming in on time or early before they would need to begin therapy. Only 3% of these patients would have a new AIDS-defining illness or death within the next year. But if the patient was coming in with a CD4 count of less than 50, notice that 22% of these patients would have a new AIDS-defining illness or death within the subsequent year. Notice when you compare it to other interventions that we do for chronic diseases in the United States, the significant per-person survival gains of antiretroviral therapy, particularly when you compare it to something like chemotherapy for non-small cell lung cancer. So early treatment and testing saves money, which most people think that the costs of antiretroviral therapy are going to be astronomical if we're starting to test people earlier and treat them earlier. But the costs are actually offset by lower inpatient and outpatient costs because you're diagnosing people at a higher CD4 count. So notice in this particular graph on the top here, you're talking about HIV patients with the lowest CD4 count cost the most for care. And this is mainly right up in here. The inpatient care can be extremely expensive. So if somebody's coming in, for example, with an opportunistic infection like pneumocystis pneumonia, I had a patient who was in the ICU for 4 months before he got out. Now that is very, very costly care. So if we're testing people earlier, then they're not going to be coming in with a CD4 count of less than 200. The whole goal of getting people on antiretroviral therapy early after diagnosing them early is that they never get to this CD4 count of less than 200, which again is across the board the most expensive in terms of cost. So one of the things that we did at the VA, and I put this out just as an example of what can be done, is an HIV screening reminder in the electronic medical record. So I showed you for Oregon that we had 40% of Oregonians had been tested for HIV. Well, when I took this on in 2010, the VA region that I'm in charge of, which is Washington, Oregon, and Idaho, had the most abysmal testing rates for the VA in the United States. We'd only had 13% of patients ever tested. So we decided to do this HIV screening reminder, and within 6 months, we're able to increase the number of patients tested in our region from 13% to 24% in just 6 months. And it was actually really pretty easy to do. It's clicking on boxes and ordering the tests and printing out the materials. The other thing that was very interesting is that it was really well received. And as I mentioned, patients are much more accepting of tests if it's considered part of routine screening. They're not being singled out, that everybody gets it. So you see from the My Healthy Vet survey, the acceptance of HIV testing was really quite similar to acceptance of getting a hepatitis C test, getting your cholesterol checked, or your blood sugar checked. And one of the things, so this had been implemented in LA before we did it in the Pacific Northwest, the number of patients, the percent, who had a CD4 count less than 200 at the time of diagnosis was significantly reduced. So it was actually less than 20%. And that was having started the majority of patients presenting with CD4 counts of less than 200. So I'm going to digress for a minute and talk about HIV testing methodologies just to make sure everybody is on the same page with that. So the traditional test that we've done is when we order an HIV antibody test, what you get is an ELISA. And that's essentially you have the standard ELISA is you have a microtiter well that's coated with HIV antigen. then you put the serum of the patient on top. If the patient has a serum, in their serum has HIV antibody, it binds to the antigen, and then you put on top of that an assayable anti-human antibody. So always think of ELISA as a sandwich. So it's antigen, patient's antibody, and then an anti-human antibody there. So this is sort of our standard what we use because the sensitivity is quite good. The specificity is good as well with only a 0.4% false positive rate. So moving on to rapid testing. Now I remember when this first came out I was a little reluctant. Is this really going to be as good as the blood test? Well, in actuality it is. The sensitivity and specificity are both 99%, and this is because the amount of the IgG in saliva is well above the 0.5 milligram per liter level that's necessary for detection of antibodies. So remember, this is an ELISA test. It's exactly the same type of test that you do for the blood work when you order an HIV antibody, and it's very simple. It's similar to a pregnancy test in the way that it looks and the simplicity, and it can be read in about 20 minutes. Yeah. So, but the one thing, just as an aside, that you always want to remember, a patient is never diagnosed with HIV until they've had their confirmatory Western blot. And this is the test that detects antibody against viral peptides that have been separated by electrophoresis and blotted. And you see on the far left what a negative and a positive control look like for a Western blot. So when you take the ELISA and Western blot together, it gives a 0.005% false positive test. So this testing is very, very good, both in terms of the sensitivity and the specificity. I did want to comment for 1 second on false negatives, which the main reason that we see false negatives for the antibody test is due to, you've probably heard the term before, the window period. And what we mean by that is if you look here, so this is time 0, which is when someone gets infected with HIV. You don't start to see antibody until between 10 and 20 days, so roughly 2 weeks. But it isn't until about 3 to 4 weeks that the antibody level reaches such a level that it could be detected by the test. So in that time frame, if you think somebody has acute HIV, you actually have to send off the HIV RNA PCR, which is a separate test. And this is one of the most confusing points about HIV testing. So moving on back to recommendations to facilitate routine HIV screening that you can try, I would have to say the thing that was the most helpful was the very simple act of providing HIV testing educational materials to the patients. That helps a lot for us at the VA in that the patients, you know, there's always downtime for patients while they're in the waiting room or in the lab. And if you can find, which we do have for the AIDS Education Training Center, we have it at the VA, very good patient educational materials. Another thing to remember is the option of opt-out testing, because specific informed consent is no longer mandated in Oregon. And those of you that have been practicing for a long time, as I have, remember the days of having to run around and try and get a written informed consent, and that was always very prohibitory. So that has been lifted. So we no longer have that as a block to getting HIV testing. I already discussed the HIV testing clinical reminder. That's one example, which I'm happy to chat about if people have questions about that at the end. Build an HIV screening notification and opt-out options into clinical materials and general consent for care. Advise patients regarding the possibility of false positives and the need for confirmatory testing prior to screening. And then make a positive plan for giving positive test results and referrals to an HIV proficient provider. So in summary for my part, I just wanted to reiterate the fact that we are doing HIV screening so we can make the diagnosis of HIV in a timely fashion, which allows the patient to get linked to care, which in turn not only improves the survival and quality of life for the individual patient, but also helps us prevent new HIV infections in our community. So Dana Morrison, who is our AATC program manager, is then going to talk about the linkage to care component.
Thank you, Melissa. So I'm going to start by going over the HIV care continuum just to give you kind of a place of reference. So we start with HIV diagnosis on one end and then go to linkage to care, and then there's this receiving of antiretroviral therapy. That's what the ART stands for. Notice there's this deviation from this linear process where we're going into this re-engagement in care, because engaging in antiretroviral therapy is a lifelong process. Things happen in people's lives. And so we need to make sure that they are retained in care so that they can maintain their treatment so that we get the positive health outcomes, not only for the patient, but for the public health as far as preventing new infection. So one thing you'll see is this continuum is being used by the National HIV Strategy, and there are these 2015 goals. And those goals, just to keep in mind, and this is where some of your UDS measures are coming from, is this national strategy is to increase the awareness of HIV infection up to 90%. And so that's reducing that number of undiagnosed individuals who are most likely transmitting at least 50% of, or are responsible for 50% of new infections are from those who are undiagnosed. We also want to increase linkage to care to up to 85%. And that increased Ryan White, RWs for Ryan White clients in continuous care from 73 to 80%. So that's that retention and care, so that we get an overall increase in the proportion of HIV people, people living with HIV who have undetectable viral loads. So this is the HIV treatment cascade, which kind of is, these are national numbers, because one of the questions you might be asking yourself is, how do we know who's undiagnosed and where does that come from? So there are two articles that came out in 2011, the Gardner and Cohen articles, that really addressed this and did a lot of mathematical modeling that I'm not going to go into, but that's where that 20% number comes from. And of those that are diagnosed, you'll see about 80% are diagnosed, and these both studies kind of corroborate that. Only 50% are retained in care. And as you go on through the progression of treatment, you get this very low percentage of the population that has a reduced viral load and is not transmitting the virus. So what this means is that undiagnosed HIV infection is a hidden threat, and that's why there's this big push for HIV screening. Transmission rates are 3 to 7 times higher in those who are undiagnosed, and that 20% of undiagnosed is responsible for 49% of new infections. HIV testing has a huge influence on linkage to care. It's the role of that primary care provider to have a positive interaction with their clients so that they not only accept HIV testing but are willing to engage in care and do that linkage to care. And that's where it comes down to your role as being an active referral source for services. There has been data that shows that when people are tested in community settings, there's a delay in that linkage to care. And so there's a real push to kind of step up that involvement at that level. In Oregon, we're actually not doing that bad. So I showed you the national numbers. In Oregon, we have a really great thing. And the biggest difference you're going to note is our HIV infected versus our diagnosed. This is our screening gap. But when you get to linkage to care, we're doing really, really well. There's some 2013 numbers that are not published yet, but I wanted to just bring your attention to that show that we're thinking in Oregon this 20% difference might be closer to 85 to 90% of our cases are diagnosed, and of those 84% are retained in care. 71% of people living with HIV have an undetectable viral load in Oregon according to the 2013 numbers. So we are actually doing really, really well, and Margie and Anik are going to talk about what that looks like, what our case management services and partner services look like to help that. It's the job, though, of those primary care providers and FQHCs to kind of reduce this gap because, like I said, it's mathematical modeling. It's not, we don't really know the reality, and we need to make sure that we're really on top of that. There are, of course, lots of different barriers to why people might have problems linking to care. One of the key ones for Oregon to always keep in mind is a lot of folks who are testing positive outside of the Portland metropolitan area, and as you saw in those numbers at the very beginning of this presentation, the balance of state has increasing numbers of people testing positive. Those folks are traveling sometimes up to 4 or 5 hours to see an HIV provider, and that is a huge not only financial but structural barrier to care that we need to be aware of in working in these systems. So in summary, linkage to care is a shared responsibility of the diagnosing site, HIV clinic, and public health. Linkage success is your first visit within 3 months, and nationally 1 in 5 do not successfully link to care. Partnering with testing sites and public health will improve linkage to care programs, and like I said, in Oregon, we're doing a really great job. Oops, sorry. And because of our case management services. But the provider and clinics still have a role. Intervention for no-show for new patient appointments, and also orienting patients to the timeline of HIV care in the clinic, letting folks know that they need to initiate treatment soon so that they get those positive health outcomes, because ideally we never see people have their CD4 counts drop below 200.
So before you go on that, there is one question from Iowa. Is there a reason why Oregon is not using rapid blood HIV screening such as Clearview Complete or INSTI?
So I think most of the institutions decide what they're going to use for HIV testing based on cost and what they've already invested in time-wise. So I can speak to up at the VA, we had a deal, so we were doing ours were about $8 a pop. The rapid testing was actually more expensive because we were buying the kits, and that was the deal that we got. But I think as the price of the kits come down, we're going to start to be seeing more of that, because the rapid test, whether you do it the blood stick, which is exactly the same as you do for like a diabetic, or the oral, are equally sensitive and specific. So those really, in my opinion, should be made first line, because you can get the results back in 20 minutes while the person is still there. But I think previously cost had been an issue because those tests were more expensive.
And there's also another recent article that came out that talked about the cost effectiveness of using the rapid test in relation to people getting their results. A lot of times people might say, oh yeah, sure, do a blood draw, and then they never show up to receive their results or even to get the confirmatory testing, whereas with the rapid test you get that result within 20 minutes. And especially for hard-to-reach populations, that's probably a more cost-effective measure, but that article that just said that came out in the last year. So I would say that there's also this lag time in that process.
Thank you.
So before Mark and Nick talk about linkage to care and what that looks like specifically in Oregon, I just wanted to go briefly over what the AIDS Education and Training Center is and what we can do, because we are a resource for FQHCs, and I'm not sure that many folks know that. So we're the training arm of Ryan White HIV program, and it's a national network of leading experts. We do clinical consultation, provide technical assistance, and also do kind of one-on-one mentoring for healthcare professionals. But the goal is to ensure high-quality comprehensive care for people living with HIV. This is a current map of the regions, and you'll see that this is a nationwide program. Generally speaking, there's a person like me in every state and a person like Melissa. So you have a local performance site coordinator and a medical director. Some of that changes based off of prevalence, but it gives you an idea of where the scope of this program. We have different training modalities, and I'm just going to bring your attention to a few. One is the HIV web study. I put the image up there. You'll notice there's this routine testing and screening and other interactive tutorials. Those all offer continuing medical education credits for providers that take them in their self-paced tutorials. So we do different things that are online to get more information, but we also have programs that go from just didactic presentations to conferences to mentoring, as well as the ECHO program. In the ECHO program, we have a few different sites in Oregon, provides weekly case consultation and teach and talk trainings with Dr. Spock out of Seattle. And it's a web-based learning platform. It's not a webinar per se, and it's not a conference call. You actually get 60 or so providers that are all working with patients that are living with HIV, but it's not necessarily their primary caseload. The goal is for people who see around 10 patients with HIV in their practice. And you know, I sat in on one, and you got to ask a question, say you wanted to change someone's treatment or add a different statin or something to their treatment. Everyone gets to vote, and you get your peer of medical professionals giving you input on how you treat that patient. So there are some changes to our program that I just wanted to bring your attention to. Mostly is our region has been joined, so the mountain states and the Northwest AETC are joined together as the Frontier AETC. So you'll hear that word beginning in July. We're still the same people. And there's been a little bit of restructuring of funding based off of prevalence. Our target population has expanded to include allied health professionals, But the thing that's most relevant for FQHC is 40% of our budget is allocated to practice transformation, which means we are identifying FQHCs in Oregon that meet specific criteria to work with them to do a needs assessment of where they're at on the HIV care continuum and where they want to be, and then designing a training and program to meet those needs. So we are working with Outside In, Wallace Medical Concern, and NARA on practice transformation, but are open to sharing those tools and those trainings with any FQHC that's interested. And so what this looks like, this is the continuum for HIV diagnosis and clinical care. Some folks are at the pre-screening or where they're doing HIV as part of diagnostic testing but haven't implemented a full routine screening program. And so by looking at this, you can see, I don't like using the arrow because it keeps moving my slides, but you can see that you can move up the tiers. A tier 5 would be like the Multnomah County HIV Clinic, which is an FQHC that provides expert care. They are a preceptorship site for the AETC, which means you can go and do training with their providers, a 2- or 3-day session, not only to learn how they do HIV care, but also what that medical home model looks like, and it's completely funded by the AETC to do that project. So if you have questions, Melissa Murphy is available for clinical consultations, and I'm the person that helps organize trainings in your area or works with providers. And with that, I'm going to turn it over to Margie and Anik to really talk about what linkage to care looks like in Oregon and why we are being so successful when things are a little bit more stressful on the national level.
Hi. So I wanted to talk a little bit about the Ryan White HIV/AIDS program. It is the largest federal program that's focused exclusively on HIV/AIDS care. There's funding that comes in under various what are called parts, and we won't get into all the different parts, but just to let you know that the Multnomah County Clinic that folks have talked about also gets Ryan White clinical care funding for their medical home model. These federal grant funds fill the gaps in care, specifically for low-income individuals who are living with HIV disease. The point of the funding is to ensure that nobody goes without care simply because they can't pay for something. We are the payers of last resort, and what that means is if somebody else will pay for it, then Ryan White is not allowed to pay for it. And that the HRSA HIV/AIDS Bureau does specify service categories that we are allowed to pay for using these funds. So, for example, acupuncture is outside of using it for substance abuse treatment is not an allowable service. So we don't have complete freedom, but the other part to note is that we are guided by a community planning body for making decisions about how much money goes into different service categories. So Dana already talked about the continuum of care, or what is also sometimes called the cascade. And we really want to let you know that we focus on all of the stages of the continuum of care. They already spoke about increasing testing for HIV disease, and Anik and I will be talking more about the linkage and the engagement and retention. So and when you look at this slide and look at virologic suppression, that's really having an undetectable viral load, which reduces the transmissibility for that. So what we wanted you to know is that one of the concerns for testing is usually that folks don't really feel like they're comfortable giving the results. The state of Oregon has created resources that are listed here on your slide, and they're also listed at the website for the Oregon Health Authority. There are also disease intervention services which are available, and I'll show you a little bit about where those services, how those services are organized in Oregon. Disease intervention service specialists are very, very skilled at locating clients, gathering epidemiological information, eliciting sexual and needle-sharing contact names, also referred to as partner services, or descriptions in social media identity and referring for testing and treatment. They do this all while teaching ways to reduce onward disease transmission. So they really do an job of sort of finding partners at the same time as helping people figure out how they might reduce their own risk behaviors. The state STD program has 3 DIS, each with multiple county assignments outside of Multnomah County. The DIS staff are really good resources if you have questions about how to deliver a test result. On this slide, you can see these horizontal layers will show you how the DIS intervention services are organized. And if you want to speak with state STD staff, there's a phone number here on your slide. There's also a team of 6 DIS at Multnomah County Health Department. If you wanted to access DIS as a resource in Multnomah County, you can call the Multnomah County STD program, and again, that number is on your slide. I would really encourage folks to speak with the DIS to whom you have access if you do want to give a HIV test result, because they're really, really excellent resources for all of us. So in talking about linkage to care, so you've found now that there is a client who has HIV disease, you want to link them to care. Linkage to care is defined as initiation of HIV care. The metric, as we've mentioned before, is that there will be a completed visit with an HIV medical provider within 90 days after their diagnosis. And the HIV/AIDS national strategy goal is 85% linkage within 3 months. Anik is now going to tell you a little bit more about how HIV case managers can help with that linkage. So DIS often give you the result, but the case managers are often really critical to that linkage piece.
All right, and I am going, it looks like can you try talking?
Yes.
Anik, are you on the line?
Can you hear me?
Yes, all right. And
Okay.
I will forward your slides as you need.
Okay, great. So thank you very much, Margie. Yes, definitely HIV case management is a significant resource in the communities that you all work in terms of linkage to care, but also in accessing HIV services. So HIV case managers are trained, specially trained, and very knowledgeable about the resources and the programs that are available to people with HIV in every community. Case management is available in every county in Oregon, and it's important to recognize that the special training that case managers receive make them experts around helping individuals navigate these complex systems of care that after diagnosis they feel overwhelmed by. So upon a referral, whether that's coming from an FQHC or a direct referral from a private medical provider or a self-referral from the client, a case manager will assess the client's overall needs. And they'll also identify what barriers the client has to care. Case managers can help with identifying HIV providers within the community, which includes, of course, the Multnomah County Clinic that has already been mentioned, but also a network of private HIV providers across the state. They're very knowledgeable about getting clients access to health insurance and other benefits that are going to help stabilize them and address those barriers. They provide information and referral resources. They can advocate on behalf of clients for those resources, help them with applications to ensure access to those services. In some cases, they're able to provide direct supportive services that help retain people in care. An example of that would be transportation to a clinical appointment. In addition to just kind of benefits assistance and information and referral, we do have a set of specialized case managers, which we refer to in our system as medical case managers. Again, these folks are available across the state. They are licensed nurses. In some cases, they're AIDS certified nurses, certified on the national level. We also have specialized social workers that are providing medical case management services. And these folks are really a part of the medical team. So they're very much available to assist busy providers in helping with things like medication adherence counseling, patient education. They can help with treatment plan follow-up and monitoring. They provide education around risk reduction and support. And they also are sometimes the ear for the medical provider around identifying needed interventions. So definitely, see them as a resource and refer to them when you do have someone who has been diagnosed with HIV. The thing to also note is that these services are available to anyone with an HIV diagnosis, regardless of income and regardless of citizenship. So our mission is access and retention. Next slide, please. So this slide actually just gives you a visual understanding of how case management services are delivered and which agencies are delivering those services. So as Margie mentioned, there is some different funding and how funding is distributed. The TGA, which is referred to as the Transitional Grant Area, receives a certain pot of money, and Multnomah County Health Department is responsible for the services that occur, the case management services that occur within that light purple area where you see the TGA counties. Within the TGA, case management is delivered by various agencies, which is dependent on where the client receives their primary HIV medical care. So looking off to the darker purple area, Eastern Oregon Center for Independent Living is a nonprofit organization that delivers services to people with disabilities, and also that includes people with HIV. They actually have offices in the Dalles, Pendleton, and Ontario, but their services occur within that entire area. So they're traveling to provide case management as needed throughout the jurisdiction. The lime green area, which is HIV Alliance and is the largest nonprofit outside of the Multnomah County area delivering case management services, they serve about 750 clients a year. They have offices located in Salem, Eugene, Roseburg, and Medford, and they also have staff that are traveling to each of the jurisdictions to deliver case management. Persons who reside in Lynn or Benton County receive their services through Lynn County Health Department. And the rest of the counties that have independent colors are service providers that deliver case management through the local health department. So that just gives you a summary of how services are delivered. Next slide. So in addition to all of the services that case managers are able to provide, they can either refer, as Marty said, because we run our program as funds of last resort, they attempt to refer for supportive services within the community. However, there are resources through Ryan White that allow us to provide supportive services when those services are needed to address a barrier to care. So some of the services are listed here, include housing resources, food and nutrition, mental health and substance use treatment, medical transportation, dental care, psychosocial support, and emergency assistance. And, in some cases, it's not always necessary for the individual to be enrolled in case management to access these services. However, I would encourage you to refer to case managers because they're definitely the people who keep up on the resources that are available and are able to access often those special resources if there isn't a community provider that's able to address the need. I guess I also should mention that for supportive services, although there's no income requirement for case management, there are income limitations, and services can vary by county depending on availability of funding. So that's something, again, the case manager can help determine. Next slide. So the Care Assist program is Oregon's AIDS drug assistance program. This is one of the most significantly funded Ryan White programs across the nation. Care Assist is really about helping people access and engage in medical care and adhere to medications. They do this by basically assisting with enrollment of health insurance coverage for all people with HIV in Oregon. They're paying premiums. They'll pay copays and deductibles on clients' behalf. So people in Oregon really have 100% access to health insurance, regardless of citizenship. So again, these services are available to all people with HIV. Now, with Care Assist, there is an income cap at 400% of federal poverty at this point, which is about $46,680 for a household of one. So that gives you an idea of eligibility. Staff within the Care Assist program can help people enroll in insurance. They do have programs that even assist people who are uninsured at the time of enrollment and will pay for some limited financial assistance in order to get people access to medications quickly and moved on to an insurance program. And they also provide additional services that kind of just address overall health and wellness, which includes tobacco cessation support, dental insurance coverage, which is new, and adherence monitoring and follow-up and support. Next slide. So this just gives you contact information for both Margie and myself. I work for the Oregon Health Authority. We administer case management contracts outside of the TGA, so within the balance of state. Margie is the manager and administers for Multnomah County and administers contracts within the TGA. So that gives you kind of a reference as to who to ask questions if you have questions about a certain community. And then next slide, please. And then in terms of actually identifying services available in the community as well as the case manager that you can refer to, there are two links here on this slide. The HIV/STD hotline is a great resource just to give you kind of an overall understanding of all of the services available within a community. It has a really great ability to search by county and dependent on what you're looking for, whether that's housing or legal or mental health or case management, you can use that resource for kind of everything you're looking for within the community that can help address client barriers and issues. The other nice features that they have is a downloadable resource guide. They have a live chat feature, a texting feature. So they really make themselves accessible to both the public but also as a resource to all of you folks. And I know Margie has some pre-printed copies of the resource guide. If you want a paper version, you can contact her for a paper version. And then that second link is actually a link to the OHA website, and it is updated with case manager names and contact information, so you can very quickly determine who you need to contact within each county in Oregon in order to make an appropriate referral to case management services. And I will turn that back over to Claire.
All right. Well, thank you for sharing that information. I learned a whole lot just now, and I have a lot that I want to share back out to our clinics about how they can find out some specifics about who to refer to locally and how to get a hold of case managers, because now we're equipped to make sure that they all know. Well, thank you for everyone for participating today. As I said, or somebody mentioned earlier, we are recording this, so we will put this online as well as links to all these services and our fabulous presenters today. So thank you, everyone. And we will be in touch. All right, thank you.
Thank you.